Great. Well, good evening, everybody. It's nice to see everybody on our next CDMS virtual tumor board. This evening's topic is melanoma, which is always a great topic, especially in its multidisciplinary nature. So we welcome all of our participants today. I'm Jeff Liu. I'm a head and neck surgeon here at Temple and Fox Chase. I'll be sort of manning the chat box. Feel free to send me questions directly into the chat, either directly or put it out globally, and I'll try to prompt our presenters. And with that, I'd like to introduce our organizer and moderator for today, Dr. Sean Surdharan from University of Pittsburgh, excuse me. Take it away, Sean.
Thanks, Jeff. Appreciate it. Welcome everybody to the Advances in Melanoma Tumor Board. So I'd like to thank everybody that's participating. I'll kind of go through the list of people. It's Dr. Our two discussants will be Dr. Trevor Hackman from the University of North Carolina, and Dr. Diwakar Dewar, who is a medical oncologist specializing in derm-onc, and he's here at the University of Pittsburgh, where I am as well. Our three faculty that are presenting are going to be Dr. Rob Lindow from Nebraska Methodist Hospital, Ann Kane from the University of Mississippi, and Dr. Ryan Gepford from MD Anderson Cancer Center. So we'll take some questions in between each case, and we have about 3 cases to present. So with that, I think that we'll start with our first case will be Dr. Rob Lindow.
Thank you very much. I'm going to share my screen here. Well, I thank you for this opportunity to be part of these virtual tumor boards. I think they're very important structure for our fellows. So once again, thank you for the opportunity to be a presenter today. First, the patient that I would like to discuss is a 67-year-old gentleman who presented to my office with a right neck mass. And that was the beginning of this year, around March of this year, so not too long ago. Back in November of 2022, he had a pigmented lesion on his right back scapular area, which I never got to see. It was evaluated by the dermatologist. Biopsy was performed on that, and it was a T2A malignant melanoma. It was 1.3 millimeters in depth. He was sent to a plastic surgeon. They did a gene expression profiling on it through Castle Biosciences, which put him at a low risk of a class 1A of having a positive sentinel node. So the plastic surgeon did a wide local excision alone without any further sentinel node workup or any other staging workup. The final pathology from that specimen did return as a T2A malignant melanoma. It had 1 mitotic figure, no other adverse risk factors. Patient then presented to the clinic 4 months later with a right neck mass, which was FNA'd for malignant melanoma. That's a picture of the neck mass. He had a PET scan performed, which demonstrated regional disease only. So the first question that I had put out there with this case is, what is the role for gene expression profiling in cutaneous melanomas? And how are people utilizing that?
All right, that's a great question. So, hi guys, my name is Diwakar. I think I'm probably the only medical oncologist on this. So, what have people heard about gene expression testing?
You may not get much response from the audience, Diwakar. So maybe you can.
All right. So, so the interesting thing about gene expression testing is, so we've got. It's very important, I think, for you guys to know this, because for the vast majority of head and neck oncologists, you're seeing 2 cutaneous malignancies, right? So it's melanoma, rarely basal, but also melanoma and squame. And there are gene expression tests for both melanoma and squame. And so it's important, I think, for you guys to be familiar with the literature. But let's very briefly think about a different paradigm, and that is breast cancer. And so in breast cancer, if you have somebody with a 2-centimeter breast tumor, so that's a T1 lesion, you come in, the first thing you do is you either get MammaPrint, Oncotype, there's a third particular gene expression test as well. But the point is, the idea that gene expression profiling is ingrained in the management of breast cancer is not news. In fact, it's information that's about 10 years old. And the reason for that is because the purpose of the gene expression test is not just to prognosticate, but it's also to predict value. So it predicts the value of adjuvant therapy. So that's a very, very important distinction. It's not merely a prognostication tool, but it's also a predictive biomarker of the benefit of adjuvant therapy. In this case, in the context of breast cancer, at least for the benefit of adjuvant hormonal therapy. And the reason that's important is because, when you think of the surgery that you guys are discussing, the primary reason for sentinel node staging, or, in this case, this is nodal dissection that is going to be discussed, but the primary role for sentinel node staging is actually prognostication. So the real question that you would have if you're a surgical oncologist is, how much does gene expression testing add to sentinel node staging? And as it turns out, we don't know that. In fact, we don't know the answer to that at all, because that experiment has just not been done. And as a result, we just don't know whether gene expression testing adds to sentinel node staging. What we do know is that in the absence of knowing anything about the nodal status, gene expression profiling reasonably does a decent job of predicting high risk, low risk, and intermediate risk patients. It adds a little bit to AJCC, not much, but a little bit. And so therefore, rightly so, opinion is divided. On the NCCN, this is a class 2 recommendation, so it's not strongly recommended. It's no level 1 evidence, but it's a class 2 recommendation. And as you've seen in this case, this particular instance, the gene expression testing, if it's completely relied upon, can actually lead you astray, because it gives you a false sense of the reassurance of it being relatively low risk. So the takeaways are, gene expression profile testing in other areas of oncology are ingrained. Gene expression profiling testing in melanoma and cutaneous squam is something that head and neck oncologists absolutely has to know about, because it's very commonly done. Whether or not it's rightly interpreted is a separate question. But very importantly, it's because of the nature in which the tests were done and the way in which these tests were developed, there's no prospective level 1 data to guide the use and the interpretation of these tests. And they're interchangeably used for both prediction and prognostication, though they've got probably more value for prediction and more value for prognostication and very little value from prediction. They're unfortunately interchangeably used for both. So that's a medical oncologist's long-winded way of saying it's controversial. But us medical oncologists, we like to talk.
Trevor, are you routinely using this testing?
No.
Yeah, we're not routinely using it either. I would agree with the sentiment that it doesn't supplant, in my opinion, the use or the need for sentinel node. It may be another adjunct if you have a negative sentinel node, but you think somebody's high risk. But I don't necessarily know that I would use it to supplant sentinel node.
And I would like to add, I did not send this because I agree with you guys. So this is the just reiterating what current statements are on the NCCN guidelines regarding the gene expression profiling, that it is not recommended at this point in time. I utilize it for trying to figure out those patients that I need to follow closely, but I never do it as a treatment, and maybe help guide the image that I would use afterwards for like a lower stage melanoma, but never in place of a standardized treatment. So now he's got a positive FNA. He only has regional disease. And so these are the treatment options that were discussed with him. Do you do a neck dissection, and what levels would you do if you were going to do this neck dissection in a primary tumor that was on his back/scapular area, and he has this isolated level 4 lymph node? Would you do a neck dissection with possibility of adjuvant radiation therapy? Would you do a neck dissection with post-op immunotherapy? Or should this patient get neoadjuvant immunotherapy?
So So this is a very, very interesting area. The evidence for this has just dramatically changed in just the last couple of weeks, right? So again, I like to talk about paradigm. So in the paradigm of breast cancer, we've been doing perioperative immune therapy for eons, right? So we've been doing perioperative therapy, not necessarily immune therapy in breast cancer since the early 2000s. Perioperative immune therapy in melanoma was being done as a, as an investigational area of interest for about a decade or so since the newer drugs emerged. But it really took a good friend, a close colleague of mine at MD Anderson, Sapna Patel, to design what is probably the best evidence we have of doing this. And so this is SWOG 1801. It's a New England Journal paper, just came out a couple of weeks ago. It has been circulated, I think, in the meeting notes. And SWOG 1801 is really a pivotal trial, right? So what SWOG 1801 did was it asked the really essential question, which was, if you give the same damn drug preoperative versus postoperative, are outcomes better? And as it turns out, it doesn't take a genius to realize that it actually does improve survival outcomes. So the study design is a randomized phase 2. The key thing to understand is, unlike medical oncologists and surgical oncologists debating over PAT-CR rates and toxicity and all that sort of nonsense, the key thing in SWOG 1801 was event-free survival, right? So the proportion of people who relapse or die from cancer, which is, as it turns out, exactly what you're communicating to your patients. So what SWOG 1801 showed was that the event-free survival with the same drug given perioperatively was significantly better than the drug given postoperatively. And the drug was pembrolizumab, standard adjuvant therapy in the context of stage 3 melanoma, given perioperatively for 9 weeks or 3 cycles, improves event-free survival significantly. So the hazard ratio is huge margin. The key thing that I explain to patients is that patients don't really understand hazard ratios. The way I explain to patients is, you've heard of the Moderna vaccine, and the benefit of neoadjuvant compared to adjuvant is the benefit of the Moderna vaccine. So it's pretty damn good. And the important thing, I guess, to understand is that the perioperative immunotherapy results in a 21% PCR rate. This is fairly consistent with what we've seen with single agent immunotherapy. The reference study to quote is Alex Huang from Penn. And the toxicity is negligible. The key problem with perioperative immunotherapy from a surgical perspective is really the fact that even though a certain proportion of patients are going to respond very nicely, a certain proportion of patients are actually going to fail perioperative immunotherapy, and therefore close communication between the medical oncologist and the surgical oncologist in this setting is essential. In fact, in the SWOG 1801 trial, in Sapna's trial, about 10 patients actually did not make it a surgery. And those patients did not make it a surgery because their disease grew and they became unresectable. So right now, if you had to ask this question, the answer would be, you'd have to discuss the surgical plan with the surgeons, but there's good level 2 evidence. It's not a phase 3 trial. Those trials will probably never happen, but a randomized phase 2 trial with a survival endpoint that has resulted in the drug getting an NCCN has demonstrated that neoadjuvant immunotherapy improves survival. Now, there are many nuances to this. We talked about some of these nuances, but you have to think about close communication. I know when Dr. Sridharan and myself put patients on this trial, we are always talking to each other. And I think that kind of communication is very important. You need to be at a system where you can operationalize this too. So pathology, the role of the pathologist in helping you define who is a good responder and who is a poor responder. And then the areas that are completely unknown, which is the extraordinarily good outcomes that were seen with PCRs. Basically, if you have a PCR, your risk of relapse is less than 4%. In a paper that we published in Nature Medicine about 2 years ago now, is well known. But what if you have, anything less than a PCR? What if you have a 10% residual tumor? What if you have 20%? What if you have 25%? We just don't know what those things mean, and we need larger studies for that. But the short answer at this point in time is, if you can, and the patient is not contraindicated, no massive contraindications to immune therapy, perioperative immunotherapy, 3 cycles or 9 weeks, level 2 evidence for improved EFS.
I would agree. I think if you were to ask my fellow from 3 years ago, they would probably tell you next section with adjuvant radiation therapy. The fellow a year ago, it's next section with post-op immunotherapy. And now I think that the current fellow would tell you neoadjuvant, and I would agree. And furthermore, the patients that don't respond to the neoadjuvant regimen, you have to ask the question of, those are the patients that may not have done very well if you had done the surgery, done the radiation therapy, done everything else, and then they're still the ones that have a rapid relapse. And so the question really with the neoadjuvant approach is, are you identifying the patients that you know are just not going to do well, and then you're not putting through the morbidity of surgeries and radiation therapy that were probably ultimately going to be ineffective, and you are capturing those that have the biologic capabilities of having long-term durable disease control with their melanoma. And so it doesn't really make the surgery harder. That was also a myth that people were worried about in the realm of neoadjuvant immunotherapy. That also makes the surgery harder, dissection more difficult. It causes some inflammatory reactions, some fibrosis, but it's really not a major contraindication. It doesn't make surgery more difficult. So I would favor at this point in time the neoadjuvant approach as well.
Trevor, to follow up on that, so what levels of the neck dissection would you perform? This is a back melanoma now in the neck. So is it a level above and below, or is it 1 through 5 for you?
But I mean, this one, I think if it's a back melanoma, so you've got to think about posterior triangle. And I think that you have to, if you're going to do that neck dissection, then yeah, you're doing a more comprehensive neck dissection, because the intervening lymphatics, if you're going to do the neck, I would probably do probably a 2 through 5. I don't know if I'd go up to level 1. I don't know if there's much utility in that, but I probably would do a 2 through 5 if I was in the role of neck dissection with adjuvant therapy. In this role, if you give neoadjuvant immunotherapy, and then there's a radiographic CR, that also becomes then the difficult question: is it worth it to do the morbidity of a comprehensive neck dissection on what looks like a radiographic CR, or are you going to choose another modality of observation based on that response? And that's another, I think, difficult question to answer. Right now I'm leaning towards probably doing the surgery, but there would be another role where if you have a phenomenal response, then the question is, do you accept that phenomenal response? Currently, I would do the surgery, but I'm leaning towards, can we trust radiographic CR in these settings?
Yeah, I think there's some more evidence to be had for that, for sure. Rob, you want to finish up your case?
Yeah, so this is the data that was presented with this paper that was published in March of this year, talking about the event-free survival at 2 years of 72% versus 49% in that neoadjuvant. So I think it's very compelling evidence to put patients on this neoadjuvant. So this patient was put on neoadjuvant pembrolizumab, and we are awaiting to do his surgery. We have it with a coordination with our medical oncologist. We'll get re-imaging. And I plan on doing, and I'll throw that out there as a question too, we plan on doing a CT neck, chest, abdomen, pelvis. Would you do a PET scan for your imaging? And the neck dissection that I would plan on doing would be definitely a 3, 4, 5 in that area for afterwards.
Yeah, it's a great question. PET versus CT. I don't think it's wrong to get a PET, but I think I would be comfortable with a CT, neck, abdomen, chest, and pelvis. Like I think that would be appropriate. I don't have misgivings about doing a PET, but I don't necessarily know if it adds that much more value in my mind.
So I think the only point that I would want to want to clarify with my colleagues is that if you are talking about the initial staging scan, you should image the brain. In the perioperative trials that we've done, again, you keep in mind that the interesting thing is this is a neoadjuvant cohort. What you have not seen is the patients before time 0. In this study, if you look at the consort diagram, about 20% of patients screen failed because of metastatic disease to the brain. So when you enroll a very high risk cohort, about 20 to 25% of your patients will fail because melanoma is a CNS tropic disease, and because that is going to happen in this patient population. So in the initial staging, you have to scan the brain. Certainly at restaging, you don't have to. And whether or not you're going to get a PET or a CT, I think that really is up to the surgeon. The one interesting thing is, again, as somebody who does a lot of translational work in the space, I'll just throw this out there, is to think of the areas of novel imaging modalities. So myself, certainly some of my colleagues in Memorial, we're looking at novel PET tracers. There's certainly a CD8 PET tracer, zirconium-8, and this zirconium-8 CD8 PET tracer essentially is able to track T cells that are moving into the tumor microenvironment. So what you might be seeing over the next couple of years is if PAT-CR predicts 1-year RFS, what predicts PAT-CR?
Mhm.
So to answer Trevor's question of who can you surgically, downstage? And as it turns out, we are increasingly developing tools that allow you to predict PAT-CR. There'll probably be two tools. One is ctDNA clearance. That's certainly predictive of PAT-CR. The second is non-invasive in vivo imaging. And look, at least in the context of immunotherapy, the most viable agent nearest to market is probably zirconium CD9 PET imaging from a company known as Imaginab.
Diwakar, is there a change in your paradigm for wild type versus non-wild type?
You're talking about with BRAF. So I would say that the answer is not quite. So to summarize, essentially, BRAF is essentially a canonical mutation that is present in about 50% of melanoma. People have looked at perioperative trials. The really fascinating thing is that there have been 2 trials that were done that looked at perioperative targeted therapy as opposed to immune therapy. One was a non-randomized, one was a randomized trial that closed early, and this was done by my colleagues at MD Anderson, Rhoda Amaria, but also Jen Wago. And essentially what they showed was they actually had to close the neoadjuvant arm early because the response was extraordinarily. The interesting thing about targeted therapy, though, is that neoadjuvant targeted therapy has got 2 major advantages and 2 major disadvantages. So the major advantage of neoadjuvant targeted therapy is that neoadjuvant immunotherapy, you have no idea if it's going to work or not. You don't know it's going to work until the tumor comes out. With neoadjuvant targeted therapy, 80% of the time you're seeing a response. You see a response within a week. So you can guarantee that you're going to debulk. The problem is, what does that response mean? Right? So the whole purpose of neoadjuvant immunotherapy is to guarantee survival. You're like, if you have a path response 21% of the time, you're going to have a path response. But if you fall into the 21% of people, you're not dying of cancer. You don't need the adjuvant cycle. We don't know that yet, but we don't think you do. But the point is, you're not getting cancer within a reasonable degree of possibility. With targeted therapy, you don't know that. In fact, these people with PCRs from targeted therapy relapse just as often, slightly more often, than patients with neoadjuvant immunotherapy. And also the patients who don't respond to targeted therapy, well, those people are really in trouble. The second major, so the 2 major advantages of neoadjuvant targeted therapy are: 1, you can guarantee debulking. 2, if your whole purpose of therapy was conversion type surgery, right? And sometimes, again, we're not in the paradigm of thinking about that in melanoma, but if you have somebody whose performance status is, borderline and is thought to be improved by by a reduction in bulk of tumor, or if somebody is a few people who are complete neoadjuvant immunotherapy contraindicated, for example, organ transplant or patients with autoimmune diseases, then you don't really have much of a choice. So those are the 2 major advantages. The 2 major disadvantages are what we just talked about, which is, 1, it's more toxic. So there's a significantly higher tox profile with the targeted therapy. People are going to be calling and complaining. They won't be calling and complaining to you guys. They'll be calling me and complaining to me about how much fevers they have, how many chills they have, how they can't go to sleep at night because of 104-degree fever. So that's one issue. But then the biological problem of neoadjuvant targeted therapy is that there's no satisfaction in telling the patient that you've had a great response, because you could have had a decent response, but it's still coming back.
Thanks, Diwakar. I think we need to move on to our next case. So Ryan, I think Ryan Gephardt will present the next case.
Hi, everybody. Nice to see some familiar faces and names. I appreciate it. I'll keep this quick for discussion purposes. This is a gentleman who presented noticed a bump behind his left ear when he was washing his hair, seen by a local dermatologist with a biopsy demonstrating melanoma. He has a history of some non-melanoma skin cancers. He is from Louisiana, has some cardiac vascular history, is a non-smoker. The only picture I had of him was an intra-op photo, but essentially on exam, this gentleman is fair-skinned. He's, ambulating in fairly good physical condition, and he has this lesion behind his ear. It was a shaved biopsy, and looks like there's no nodularity or palpable adenopathy, but some surrounding looks like small satellites. This is his review of his outside biopsy. It is a 3.8 millimeters. Sorry, that does not transmit very well. 3.8 millimeters thick. There's some mitoses that is not ulcerated. There's some regression and vascular invasion. And it's present at peripheral and deep, but as a stage, it's overall 2A, it's a T3A lesion. Presume that most surgeons would be worried about this, but would recommend a wide local excision with a sentinel node biopsy. And I was curious what type of imaging people would like, how they go about that. I thought that'd be a useful question.
So I guess in the absence of, you said nothing clinically on exam. I'm a person who has an ultrasound in my office, so I probably will be doing a bedside ultrasound in my office anyway. It's free of charge. But if that looks pretty normal to me, I don't feel anything. I'm probably not getting, for this level, I'm probably not doing PET and brain MR. I'm probably leaning more towards wide local with sentinel node. I don't think I would fault somebody for getting the imaging, but for a 2A, I think I probably would, in the absence of anything on ultrasound, I probably would just do the sentinel node.
Great.
I completely agree with my colleague. I'll say that one thing about the nuance of this case, though, is when you see regression is something that in AJCC 8 is not considered a high-risk feature, but historically has been considered a high-risk feature. And the reason for that is what you're essentially looking at is the regressed melanoma is a melanoma that the actual Breslow appears to be a certain size, but actually was thicker than that. So when you see a regressed melanoma and you come away thinking, because the pathologist is measuring the slice of actual viable tumors. So think of a cheesecake, right? So cheesecake is all the way from topping down to crust. And when you have a regressed melanoma, what you're really measuring, hypothetically speaking, is just a crust. So the key question is, did you get any cheesecake, right? And so when you see a regressed melanoma, the thing about a regressed melanoma is that there historically has been a idea that you should think about how long the tumor has been there, because the presence of a regression is both a favorable risk factor, a favorable factor, meaning the immune system is attempting to respond to the tumor, but also an unfavorable factor, because it really means the tumor is slightly thicker than what it originally, at least now, appears to be. So just something to think about. Some people might, at least in this setting, some older medical oncologists have a preference when they see regressed lesions to strongly push their surgeons towards trying to do more imaging. Some of the newer guys, myself included, we're probably more just looking at the actual Breslow depth.
Precisely why I pointed that out, and I'd be happy to share a meal with you given your analogies. So this patient, he had a CT scan. I'll tell you that it's usually an ultrasound we get, and he did not have any pathologically enlarged lymph nodes. He had a lymphoscintigraphy SPECT CT, which you can see here, demonstrating some sentinel nodes in the suboccipital and level 2 regions. Just out of patient counseling and interest, I'll point this out. This is not the only risk predictions tool, but it's a nice one from the Melanoma Institute of Australia. We work a lot with that group, and just to point out, based upon these factors that you enter in, this actual patient, this generates a risk of a positive sentinel node of 70%. So we were all somewhat worried about this, but I find it particularly helpful in patient counseling to use a data-driven approach, and you can show them. There's actually a nice figure that is helpful for communication purposes, that you can bring this up in the clinic and show the patient. This patient is from several years ago, but I'm just thinking on the top of my head about trial options already for this gentleman who has a intermediate thickness melanoma, and there's a couple there, but he's not really eligible for either of them, just for purposes of discussion. This gentleman had exactly what Trevor was discussing. He had a wide local excision. He had 2 centimeter margins here, and we did a sentinel node biopsy from the areas that were lit up in the lymphocytography, and he had a delayed reconstruction. Anything specific you all want to comment about this? We like to delay the reconstruction, though I don't always do it for scalp melanomas out of patient convenience. Given my concern about this patient and my concern about some small, microsatellite or satellite lesions around it, that's why I did it.
I agree. I think delaying the recon in these cases makes a lot of sense. There's no wound care risk to doing it. There's no risk for vessel exposure. I would delay it as well. And because you can always come back later and do it, and you can cover that with the dressing pretty well.
This is a lot of information, but basically he had some residual melanoma there. And he had 3 out of 3 sentinel nodes positive. There were 2 in the level 2, and there was 1 in the suboccipital. The largest tumor burden was only 0.9 millimeters. So less than 1 millimeter of largest tumor burden. They went ahead and did some adjuvant or ancillary studies. He was BRAF wild type. Dr. Davar, you can comment whether the CPS score here is important in melanoma, PDL1 less than 1%. We talk about that a lot as a criteria for systemic therapy and other diseases, but this was his pathology report. He did have microsatellites, as I said. So then we came back to our multidisciplinary planning conference, and these are some options for the next step.
So just to go back to that earlier, I mean, not that you have to go back, but just to talk a little bit about the path report, I think there are 2 points to raise. The interesting thing is, from a staging perspective, the presence of satellites. So satellites is what is giving this guy the high risk staging, right? So what you would consider is that the presence of the satellites is really what is upstaging this guy. When you've got microscopic node positive disease, you could have a high absolute number of lymph nodes, but with AJCC, the staging classification is really very weighted, especially with 8 towards the depth of the primary tumor. So what would be very interesting in this guy's case is if he had multiple nodes that were just microscopically node positive, that would be a very different stage than if he had the presence of satellites. So that's one kind of interesting feature. If you really wanted to nerd out over surgical staging. But to me, just to talk about a point that Dr. Gepford raised, which was the presence of trials. So 2 things. There are actually, interestingly enough, some trials that are going on in the space. So the University of Pennsylvania, really one of your guys' colleagues, George Karakoussis, has done this very provocative trial of looking at pembrolizumab. And so George has essentially looked at pre-sentinel node immunotherapy in high-risk node negative, clinically node negative melanoma.
So we discussed these various options with the patient. At this time, the patient was a candidate for some of these protocols that were discussed earlier, including adjuvant systemic therapies. We had some adjuvant radiation protocols. We were particularly worried about the primary site having microsatellites and considering adjuvant radiation to that area, certainly a combination of these things. That thing being said, the patient's wife had a previous immune-related adverse event, and she did not want to have systemic therapy. He was concerned about it for some valid reasons, given his experience, and the patient elected to have a completion lymphadenectomy, which he underwent. This had 3 additional lymph nodes positive, so there were 6 positive, including what we removed, and another 70 or so that were negative. So then here we have this patient with additional non-sentinel lymph nodes positive. So this gentleman came back to our post-op appointment And of course, he has some additional satellite disease inferior to his skin graft, which we were disheartened by, but I don't think anybody would be completely surprised. We had another discussion at planning conference, and here is where we can see the benefit of this neoadjuvant approach and why some of these patients did better. So this patient we knew that he needed something other than surgery. This is what Dr. Hackman was also talking about before, patients recurring, before you've had a chance to get them healed from their surgery. Essentially, what this patient went on to was a combination of nivolumab. He did not want double agent therapy, again, given his concern about immune-related adverse event. And he also had TVEC injections concurrently. After the 5th injection, all of these lesions disappeared. They were no longer clinically evident. There was a biopsy done of the area, which showed some rare viable melanoma cells, as you can see. And he completed 1 year of systemic nivolumab, and stopped that. Again, at this time, then the pandemic was beginning, and most of his care was in transition to home. At 18 months, he developed some small nodules, about 8 millimeters. One was peripheral and a candidate for biopsy, which unfortunately demonstrated metastatic melanoma. Any comments at this point? I think I just have one more slide.
So I'll say one thing. I mean, we talked about this. You present that last part about having distant disease, and it's sort of sad that the patient recurred. But let's take a step back and think about where we were 5 to 10 years ago with melanoma, and this patient's not making it 18 months. And so I think that one thing to take a look at for the trainees now is that really immunotherapy, TVEC, have changed. This is game changers. These patients do not survive more than 3, 6, 9 months, and now it's recurrence. It's got bilateral lung nodules, but that amount of disease-free survival is impressive, and it's the advanced melanoma that we really didn't have 10 years ago. And so it is a case that reminds you that melanoma is unforgiving, but at the same time, it is. The response to therapy still is quite impressive, and it did give some meaningful, durable control, would be my thought.
I'd actually completely endorse that, and I'd highlight one thing. In the medical oncology community, TVEC has a rep as a drug that does not work. And I actually think that is completely untrue. TVEC is actually a very effective drug that just happened to be developed at the same time as a more effective drug. So you can't be blamed if you're playing on the same team as Kobe and you only score 25 points a game, right? Just because there's somebody who's better than you doesn't make you a less good player. And the problem with TVEC was that it was FDA approved around about the same time that pembrolizumab or Keytruda was. And so what we have now is a setting in which this drug is actually extraordinarily effective for the very small subpopulation of patients in whom it's designed to be utilized. And it's no surprise that MD Anderson is a place where they know clearly how to utilize this drug. But when you're at a large center, when you have appropriate multidisciplinary care, when you're triaging patients appropriately, there are indications where you can effectively use this agent, and it's really truly very effective in the right hands, even its checkpoint inhibitor refractory patients. So I'd highlight actually in this case, this is actually a very good example of a very effective use of TVEC, because this guy really responded to TVEC. He did not respond to the checkpoint, because if you're going to respond to checkpoint, you're not relapsing at a year, 8 months, a year and 6 months with metastatic disease. This guy responded to TVEC. TVEC worked, didn't necessarily work elsewhere. You don't generally have a response in uninjected disease, but this is a very good example of the suitable use and appropriate use of an intralesional therapy that unfortunately has not gotten wider traction. But hopefully there are some newer agents that you guys might be hearing about in the next 3 to 6 months, that newer oncolytic viruses that are eliciting very, very durable responses and that hopefully will have a path to registration.
So I'll ask you a question back. With the path report from his initial resection that showed microsatellites, what is your thought about preemptive TVEC injection, knowing that there's a high risk of, and was even mentioned, I mean, I think that was part of the concern was that Ryan mentioned, was the risk of the microsatellites. What do you think about preventative or preemptive TVEC in the area?
So I think, let me break that down into two questions, and that is preoperative, meaning neoadjuvant TVEC, and neoadjuvant immunotherapy in the setting of satellites. In the pooled analysis that was published by some of Dr. Gepford's colleagues and myself, very interestingly, satellites and in-transit disease were two subgroups that did not derive as much benefit from neoadjuvant immunotherapy. So these are two sort of subgroups that just for some reason, probably biological and actually more anatomical, just do not respond quite as well to neoadjuvant systemic immunotherapy with the same degree of response as, say, a nodal MET. So one issue is that the moment you see satellites, that's just a bad actor, clinically observed satellites. Neoadjuvant TVEC has been studied. There was a phase 2 trial by Reinhard Dumer looking at preoperative versus preoperative TVEC versus TVEC versus just surgery, and necessarily preoperative TVEC did quite produce a certain path response. There was not much RFS benefit. But to your point, there will be at ASCO. Unfortunately, the data is embargoed for at least another couple of weeks, but there will be a ASCO abstract discussing the role of perioperative immune therapy, combination of TVEC and systemic immunotherapy. So Nivo plus TVEC being discussed by an Italian group that I'll draw your attention to in the melanoma session. Suffice to say that I think that in this subpopulation, this is actually a good idea. It's not obviously FDA approved. You have to just clarify that based on the MasterKey 265 data, the combination of checkpoint plus intralesional TVEC did not result in an improved survival benefit compared to, again, either PD-1 alone. But in certain instances, it's worthwhile thinking about, and this is one of those instances in which one would have a discussion with our surgical colleagues about potentially considering such an option.
Thanks, Diwakar. We have about 13 minutes. I wanted to let Dr. Kane have some time to present her case.
Hey, thanks so much for having me. So I'm Ann Kane. I'm at the University of Mississippi. These virtual tumor boards actually started at the end of my fellowship in 2020. So I really enjoyed them, and this is my first time being on. So thanks so much for having me. So this is a 64-year-old female who was referred to me for a melanoma. The right lower eyelid, you can see it's just inferior to her lateral canthus. The lesion had been present for 2 months. She had no prior history of any other cutaneous malignancies, and obviously had a pretty significant history of sun exposure. She had a shave biopsy outside that showed a T4B, at least T4B tumor here with a thickness of at least 4.7 millimeters. And she came to me with workup imaging, including a PET scan, which was negative, showed no evidence of any FDG-avid, residual or metastatic melanoma. So my first question for the discussants would be, how do you manage tumors around critical structures such as the eye? Would you potentially get another surgeon involved for a tumor like this? And then how are you managing margins in areas like this?
Yeah. Very carefully. No, it's a great case. This is the merge of functional preservation, but management of appropriate margins. When it's this close to the eye, I probably will eventually have my oculoplastics, facial plastics colleagues involved with the definitive reconstruction. And then there's questions about how could you maintain this lid. I still would want to get appropriate margins. And so it may be something where I'm getting margins and at the time doing like a lateral tarsorrhaphy to protect the eye from exposure. So I think I would still be attaining margins, but probably trying to protect the eye at the same time with a temporary procedure, knowing I may have to come back in and do additional work to support the lower eyelid and prevent ectropion.
Right,
Do you ever get any Mohs colleagues involved in your cases?
For squam, yes. For melanoma, not as often. So this is one that, yeah. So for squam, yes, and basal, yes.
Go ahead, Kane. Dr. Kane, sorry.
So I did just that. So I did 2 centimeter margins. So I did a wide local excision with a sentinel lymph node biopsy. I staged her reconstruction. That's typically my preference for melanoma. And certainly in a critical area like this, where you can't really take anything back once you do a reconstruction, I did end up staging it. So what do y'all typically do in your practices? Are you typically going to stage something like this, or would you go ahead with reconstruction at the time of surgery?
I would also stage it as well. And then the goal of staging, as you're pointing out, is eye protection. So I would have a plan for eye protection, but stage it because you don't want to be covering up. So yeah, so just like the scalp lesion, this one would be staged, in my opinion.
Yeah, so that's exactly what I did. So I did the wide local excision, I did a sentinel lymph node biopsy, and I did a tarsorrhapy, and then brought her back a couple weeks later to do a reconstruction with an oculoplastic surgeon. Her final path came back with actually no residual or invasive melanoma. I found 4 sentinel lymph nodes. All of them were negative. And so her final staging was a T4B and 0, and so that made her a stage 2C. For patients like this, is there any argument for excluding sentinel lymph node biopsy in the setting of disease that's going to be at least a high-risk stage 2, just based on the Keynote 716 results?
So
Go ahead.
actually 2 questions here, right? So the first question is, what do you make of the Keynote 716 and actually the Checkmate 76K results? So both of these trials are phase 3 trials, a global randomized phase 3 trial comparing adjuvant immunotherapy, pembrolizumab, with 716 versus and nivolumab with 76K against placebo. Randomization was 1-to-1 with 716 and 2-to-1 drug to placebo in 76K, but otherwise it's basically high risk, no negative disease, right? So deep primaries, clinically no negative patients. These patients all got surgical staging, got randomized to either drug or placebo. The RFS data is pretty positive. The hazard is about 0.65. So basically it's a 36% improvement upon the risk of relapse. The way you'd interpret that is your risk of relapse on, ballpark is about 25%. You're cutting that number down by a third. Okay, so the question is, firstly, is it a good idea, right? So the provocative thing here is, I think I once heard Steve Rosenberg, right? Question of whether Steve Rosenberg is more of an immunologist than a surgeon, or more of a surgeon than an immunologist, is always something that's interesting to debate. And Steve Rosenberg stood up and said that he does not believe in adjuvant immunotherapy. And the reason he does not believe in adjuvant immunotherapy, adjuvant, not neoadjuvant, was that he believes that you can cure advanced metastatic melanoma when it returns, right? With TIL and, so on and so forth. So the reason I think that adjuvant therapy is very controversial, even though that medical oncologists, myself included, are always pushing it, is because the implicit assumption of adjuvant therapy is that you're overtreating a very, very, very large number of people. And as you go down the surgical, the staging paradigm, right, you're treating even more people. So the number needed to treat, right, it's really a statistic we don't really care about in medical oncology, is significantly high with adjuvant therapy. The other interesting thing, so suffice to say that at least in this setting, from your medical oncologist colleague would probably say that the patient would qualify. Whether or not you should do it is a separate question. And it's probably a value question. You should definitely offer some kind of imaging-based surveillance and so on and so forth. What I'll draw your guys' attention to is actually something even more provocative, which I think is something that I think surgeons should really strongly weigh in on, because this is something that is of huge importance to you guys and definitely us too. And that is, if you have a drug that is FDA approved in the stage 3 node positive setting, right? And you have a drug that's FDA approved in the node negative setting, right? What is the role of surgical staging, right? And so now I happen to be one of those medical oncologists that is arguing for surgical staging all the time, but in the registrational trials of newer immunotherapy agents that are being done right now across the world globally. There are at least several phase 3 trials that are being launched. Surgical staging is optional for deep primary tumors. And the reason for that is the control arm is immunotherapy. And the control arm is 2B all the way to 3C, stage 4A resected disease. So it's deep primaries, node positive disease, oligometastatic distant mets, right? And as it turns out, you don't need surgical staging to necessarily define whether you're in a deep primary 2B, 2C patient or 3A patient. And so I think that we are in a very, very rocky, very dangerous area right now because the pharmaceutical companies are designing trials, right? Some of us are involved, but there's a paradigm in which some people are arguing that surgical staging is less important than at least some of us think it should be. So we do need a very robust discussion about the value of surgical staging. And I personally am one of those medical oncologists who strongly believes that if you're going to recommend a treatment, you really need to know how much risk you have, because otherwise you're not speaking from any particularly strong position, because the whole point of adjuvant therapy is risk reduction. So if you don't know how much risk you have, what are you reducing it to? And where are you starting from, right? So my 2 points that I would argue about this case is that 1, Checkmate 716, Checkmate and Keynote 716 and Checkmate 76K transformational data. You'll see both results at ASCO. The DMFS results from 716 will be discussed by Jason Luke, my colleague, and the RFS and the primary biomarker results will be discussed by Georgina Long from Checkmate 76K. Both studies are positive. Both drugs, one drug is already FDA approved, the other one will be. The problem, is that in some of the newer phase 3 trials that are being done of the newer co-formulations that are studying novel drugs, 2 drugs versus 1 drug by many companies, including Merck, surgical staging is not mandated. And this is actually something that I think is crazy because it's a paradigm shift. When you think about the fact that phase 3 trials historically were always done at the point in time at which stage 3 disease was defined, which was completion of surgical staging. Now these trials do not require surgical staging. It's optional. And this is a very, very controversial thing, at least for me, that has not gotten as much debate as I think it should have.
Yeah, no, I think that's valid. Personally, I would argue for continued surgical staging. Obviously some of this data is new, as you mentioned, but also, and also to your point, the first thing that patients typically ask when they come into your office is, what's my prognosis and what's my chance of this coming back? And so having accurate staging, I think, is valid in these cases for those reasons as well. Okay. Dr. Hackman, any thoughts on reconstruction for this defect?
So yeah, you've got a few different subunit reconstructions you need to think about. Canthal reconstructions for suspension. It looks like you have at least half of the lower lid. Is that right?
That's correct.
Yeah. So you need to have reconstruction for the tendon, mucosal grafting. So my facial plastics colleague would probably want to do a bucket handle flap from the top to help do the lower lid with mucosal grafting, and then tendon repair, and then I would probably bring in free tissue for the lateral defect to take tension off. As far as what I would use for tendon repair, I probably, if I did a free tissue transfer, would probably use fascia from my flap harvest. What did you do?
So I did this with an oculoplastic surgeon. And so I did a big Mastarde flap actually, and got that lateral periocular area / temple area closed completely.
Nice.
He actually did a full thickness skin graft for the upper lid and then used the upper lid for a Hughes flap for the lower lid, and then did a canthopexy for it. So this is actually what she looks like now. So
That's marvelous.
yeah, it was a great case. It really was.
The biggest challenge, obviously, and it looks like you guys successfully battled it, is that lateral lower lid ectropion, and the hope that it looks good now, that it looks good 18 months from now, 2 years from now. And it looks like you guys gave plenty of volume, because that's for the trainees on the call who are still on. If you don't add enough volume to the lateral lower lid, then over time the graft site will pull down and you'll get lateral ectropion. And it looks like you guys gave plenty of volume, which is impressive.
Yeah. She's had, I think, one additional revision surgery with the oculoplastic surgeon. And the other thing I think that helps a lot with more prevention of ectropion is that Mastarde, and really aiming high with it to try and pull everything up, because everything falls obviously in the long term. So I think that's another thing that's helped us as well. But yeah, having a good oculoplastic surgeon is really vital in these cases.
All right. Well, anybody in the chat have any questions they want to ask with our couple minutes here? We've been told we can go a little bit past 8, so out of respect for time, I won't push it too much, but if anybody has any burning questions, we can ask.
I'll just say 3 great cases for presentation. Great discussion, great cases. Thank you for putting the effort in to put them together.
Well, thanks so much, everybody. I think Jeff Liu would like to plug the next month's tumor board.
Yes.
So take it away, Jeff.
First, thanks to all of our presenters and to all of our expert discussants. I know putting cases together is a lot of work, and really great job today, everybody. Very interesting cases. Our next and final for this year will be June 7th, Wednesday in the evening at 7 p.m. on bone reconstruction of the mandible and midface, so a recon heavy one, which would be great. Otherwise, everyone have a really great evening, and we'll see you next month. Thank you so much, and thank you again to the presenters and discussants.
Yes, thank everybody. Thanks, everybody. Thanks all the panelists and the discussants.
Thanks, Sham, for your work.
Shane.
Thanks.
Thanks, Jeff.